Hello, listeners. Welcome to IT Guy Who Lives podcast. I'm your host, Palash Gupta, Diploma in Nutrition and Fitness Sciences from INFS India, and Bachelor's in Sports and Exercise Science from Loughborough University, UK. The goal of this podcast is to understand the science and science based tools with the help of industry experts so that we can further optimize our training and nutrition goals. With that in mind, let's jump right in. Hello, listeners. Today we have been graced by the presence of Dr. Nicholas Licameli, who is injury prevention and management specialist. So, without further ado, let me pass the baton towards Dr. Nick so that he can give listeners an introduction about him, his professional endeavors, his lifting endeavors, and how this iron bug bit him and made him the man he is today. So before that, Nick, I have a disclaimer to put out, and which says that on this podcast, we actually request and urge our guests to give the longest possible introduction they have ever given. Because we want to know all the events which unfolded in front of our guests and laid down the bricks on which they have walked down this aisle and become the person they are today. So with that in mind, over to you, Nick. The floor is all yours.
Well, yeah, first of all, thank you for having me. It's awesome to be on. And wow, so you want me to talk about myself? This can get lengthy. This can get long, but we'll keep it reasonable. Um, so yeah, like you said, I'm a physical therapist. So I'm a doctorate in physical therapy, and I work with Team 3DMJ. I'm their injury reduction and management specialist. So I work with their athletes. Have some private athletes of my own that I work with virtually. I'm also the director of an outpatient physical and occupational therapy clinic. That's my full-time job. And I also work with the BFR pros and Dr. Rolnick. So kind of have my hat in a few rings. I'm also a father of two baby girls and husband to my high school sweetheart. So that's pretty much me in a nutshell. How I got to this point. Um, I always enjoyed working out. I always enjoyed science and the human body. And I was starting weightlifting around high school, maybe a little before that. Um, and then I wanted to learn more. I wanted to gain as much knowledge as I possibly could about weightlifting and training and nutrition. And I wanted more than the biggest guy in the gym was going to tell me. And that's where everyone gets the information at first. So then I stumbled upon Muscle and Fitness magazine around 17 or 18 years old. That was a pivotal moment in my life because now all of a sudden we had, in my mind, these legitimate, some are PhDs, all these authors writing about this world and providing information, practical takeaways. And so I just dove in hard to the muscle magazines, like many of us do. And then that eventually ran out, and I knew that I wanted to have more. And I started reading the same things that I already knew, and I wanted to push my knowledge to the next level. And that's where the journey kind of transitioned from the muscle magazines to more of the evidence-based community, the Lane Nortons, the 3DMJs. So that was kind of my journey through bodybuilding. And when you go through that journey, it's it's kind of scary because there's a lot of things that you thought to be true that you've molded your life around, and then you realize that they're not so important as maybe you once thought. So now it's almost like someone saying, by the way, the sky isn't blue. And you're just like, wait a minute, my whole life, like I've worked my life around the fact that the sky is blue. So it is a bit of an existential crisis when you go from that bro science to the more evidence-based, holistic, more nuanced approach. And I think that's important because I went through a similar journey in physical therapy as well. So around the same time as I was making the transition out of the bro science world to more of the evidence-based community, I was making a similar shift in physical therapy in my professional career. In school, as a physical therapist, you are we're kind of taught to be like mechanics almost. Like we look at the body, we see someone has pain, we diagnose some kind of tissue as the cause of the pain, and then we treat it with some kind of intervention, whether it be our hands, a certain kind of stretch or exercise. And we leave PT school thinking that we are going to save the world with our magical hands and our magical treatment techniques and muscle energy techniques and myofascial release techniques, and then we realize that maybe things aren't quite like that. Um, Similar to following the muscle magazines or the biggest guy in the gym, when you graduate physical therapy school, usually you have some kind of mentor. You follow that mentor, you do what he or she does, and you become a miniature that person. Um, and then it just solidifies some of the thoughts and paradigms that you may have had. And then you stumble upon Quinn Henick, clinical athlete, barbell medicine, and many, many others in the PT world. And we go through that same switch like we did with bodybuilding. We say, holy cow, all of these things that I thought to be 100% true and important maybe are not so important. Not that they don't have use, but maybe we should shift our focus here in our treatment. So, those were two shifts that I went through in my professional career and my bodybuilding journey. And I guess real quick, how I got started with 3DMJ. I started writing uh, years ago and didn't really have anywhere to put the things I was writing. I just kind of saved them on my computer and would send them out every once in a while to people that I looked up to, and hopefully they would take them. None did. And then there was a time when Tony Gentilcore, who's relatively well known in the strength and conditioning world, he was having a baby, and he said he's looking for guest writers because he's not going to have quite as much time to write. And so I said, what the heck? Sent him 3 articles, and he got back to me. And that email from Tony Gentilcore, you would have thought that like Dwayne Johnson texted me and was like, "Hey, what's going on?" Like it was just such a great moment for me, and I knew at that point things were going to change. And I wrote for Tony for like 2 years consistently, and then Andrea from 3DMJ read one of my articles on Tony's website. She knew that I was a 3DMJ follower, and she asked if I'd be interested in guest writing for 3DMJ. So if the moment when Tony emailed me was a pinch me I'm dreaming moment, when Andrea emailed me, that was everything, because I looked up to 3DMJ so much. And so when she reached out to me, that was just an awesome thing. So I wrote for 3DMJ for about a year, and then Eric and Andrea reached out to me and said, we have a mental health specialist, we have a nutrition specialist, and we think that an injury reduction specialist would help complete our team. Would you be interested in coming aboard? And that was just another fantastic moment. And I take such pride in being a part of Team 3DMJ, as a lot of our followers do. I think
Yep,
it's different. We just
different.
feel closer, I think, if you are a 3DMJer. So I understand the responsibility of being a part of the team, and I look forward to helping the community as much as I can. So you asked for a long introduction. There you have it. You got me going, and now we're how far in are we talking about myself?
Yeah, I absolutely loved it because I really want to know our guests or in any general, any kind of a person, what they actually went through and how they have done all this journey, all the paths that led to this particular moment and made them the person that they are today. It speaks a lot of how things and circumstances has played a big role when it comes to the actual progression of our career, when it comes to their professional career, personal career, or their indigenous development as well. So I literally loved your introduction. And on that particular note as well, since you bring out the possibilities of being research driven and all, and we as well labeled ourselves as a evidence-based practitioners, right? So on that particular note, I want to ask you, Nick, what does evidence-based practice means to you?
Yeah, that's a good question and a great place to start because I feel like that term gets thrown around quite a bit.
Yeah,
Evidence-based practice for me, um, and it would be the same for physical therapy as it would be for strength and conditioning or physique sport. Evidence-based practice is kind of like a funnel. Sometimes it's described as a stool, but I like to think of it more of it as a funnel. And so we start with the totality of the evidence, and then we funnel that down into our professional experience because we have to impact the raw data that we're being given. And then it funnels further down to the individual that we're applying it to. So that to me is evidence-based practice. It's taking the totality of the evidence, funneled through our professional judgment, and then down into the individual. Because what can seem great on paper
on paper.
and what can seem great with my anecdotal experience may not work for everybody. So those three kind of funnels, I think, are what evidence-based practice is for me.
Yeah, beautifully said. I agree with each and every sentence that you made, that it always comes down to that particular individual, because evidence-based practice tells us how to use those mathematical estimates derived from that population sample through all these researches, but it will always boils down to how we can practically turns those researches into practice for that specific individual who is coming to us with a thought in mind that we have something to offer, we can fix them, or we can enhance their quality of life. So that's a really segue into this session. So since we are going to talk about injury management and prevention, so before we deep dive into the this particular agenda of ours, I want us to establish some baselines for our listeners, that before we try to manage or prevent something, we actually have to know what it is actually, right? So on that term, I have read a lot of books regarding injury and pain, but the definition is really murky, right? We cannot decide or define it in a black and white terms. So on that note, how will you define pain in a layman term so that our listeners can understand what actually pain is, what they thought it was, but it is something else, to be honest.
Yeah, that's a great question, and you're 100% right that injury is very not well defined in the
Yeah,
scientific literature. So it's almost hard to how can we prevent something that we don't know what it is,
no,
or how to define it, and then if we're trying to make a body of evidence about injury, if we all have different definitions of injury, how are we going to get consistent results to then bring together for some kind of conclusion? Is injury the presence of pain? Is injury time off from gameplay? Is injury only when someone goes to seek medical help? I think either of those has holes in it. I don't agree with any of them. I think it's a bit somewhere in the middle. Pain itself, we know that pain is a multifactorial experience. It can be impacted by our mental state, our emotions, our physical state, sleep quality, things like that. So pain is also very difficult to define. There is an official definition of pain by like the Pain Society or whoever is like the governing body focusing on pain. Um, but yeah, pain is I think the main takeaway from pain for the listeners would be that pain, if we can't say what it is, we can say what it's not. What we know is that pain is not necessarily due to tissue or structural damage. We can have pain in the presence of tissue damage. We can have pain without any tissue damage. So we know that that is true. We also know that education sometimes can help relieve pain. So that's kind of where I guess we'll set the murky definitions, and then we can kind of take the conversation wherever you want.
definitely. So how does pain correlates with the injury? So if I'm having a pain and we do not have a clear-cut definition of pain first, and we neither have a clear-cut definition of injury first. So how do these two things correlate with each other, and how we can actually identify, are we having some kind of a discomfort, or is it actually a pain, or is it actually resulting in an injury? So how this correlation works?
Yeah, great question. So the first thing that I would say if someone has pain is let's rule out red flags, because most of this conversation that we're going to have is going to be how pain is usually not something serious. We can find ways to modify training stimulus to kind of work around some pain. So we'll get to that, but before we start talking about that, it's important to rule out red flags. Sometimes pain is serious. Sometimes pain is due to tissue damage or structural damage. If you roll your ankle stepping off of a curb and your ankle blows up like a balloon and it's painful, it's probably not because you didn't get a good night's sleep the night before.
Yeah.
It's probably structural damage. Now, how that pain impacts you or lingers or maybe becomes chronic pain, that is a bit more nuanced. But things that you want to think about and rule out red flags are, was there a mechanism of injury? Or is this just this kind of dull, achy pain that has no real consistency? We can't really reproduce it. We can't really improve it with different positions. It wakes you up at nighttime. Any kind of loss of bowel or bladder control, any kind of fever, all of those things are things that we don't want to try to modify or modulate on our own. Go see your doctor if you're experiencing any of those type of things. Severe numbness, tingling, that's constant, causing if it's in your leg, causing your leg to give out. Those type of things, we want to seek medical attention. Putting those things aside, if it's just the most common kind of pain that I usually see is from a lifter who just kind of develops this kind of achy shoulder
Yeah.
or low back pain or knee pain, things like that, and they don't know what it is, and then they go to Google and they have all of these different reasons for their pain. That's usually the athlete that I work with. In those cases, what I usually do is first see how it happened first. When did it start? How did it start? Was this something that's been slowly progressing for the past 6 months? Or is this something that felt great 2 days ago and then you pushed on a bench press, you felt a pop in your shoulder, and now your shoulder hurts? How did it start? Um, then I would want to know how does it behave? What makes it worse? What makes it better? Once we can build that, then we can build a bit of a plan. Um, if many times the athlete doesn't know what makes it better or what makes it worse, because maybe it's relatively new, or maybe they just never really thought about it, or they thought that their back pain was due to a herniated disc, so they said, who cares what provokes it? I need to fix my disc, and then everything will feel better. Um, so I like to see what provokes it and what makes it feel better. Once we build that, for example, if um, sitting tends to feel better than standing, well, that gives us some information. If a barbell back squat provokes it, but a leg press feels good, that gives us information. So just trying to tease out some things, if anything, just the slightest thing that we can do to stop provoking the pain and start modifying our activities so that we could still maintain a training effect without provoking that pain. Because when we have pain somewhere, it is kind of like an oversensitive car alarm. Something triggered it, and now it's heightened. So anything, almost like if you get a burn and it's like very sensitive, like if you just brush up against it, it really, really hurts. And then after a couple days, it doesn't hurt quite as much. It's not so sensitive. Similar to how pain is. It's this heightened response. Uh, it's trying to protect the area with or without actual danger. So the approach is we want to continue to stimulate it. We want to continue to load it, continue to bring it through range of motion, um, but we don't want to provoke the pain, because if we keep provoking it, then it's going to almost reinforce that signal. We almost want to give it a hug and say, you know what, it's okay. It's okay to do this. It's okay to let the knee bend, and you don't have to put up the guard so much. And the way that we do that is by modifying activities in and out of the gym, and then progressing back to where we want to go through graded exposure. So little by little, we kind of taper things back and then slowly bring them back up. What the typical recommendation is, a lot of times in my profession, which I think we get wrong a lot, and I've worked with, I've consulted with a lot of people around the world, and it's very similar. Scary how similar it is around the world. Usually, if someone has pain and they're functioning at a very high level, when we notice that they have pain, we tend to drop them all the way down. Stop going to the gym, stop squatting if it's hurting your back, and let's just get on the table and we'll do some bird dogs, and we'll do some bridges, and we'll do some stretches on the table and planks to strengthen your core, which we can get to. um, where that's kind of the last thing that we want to do. Because now, say, take
Yeah.
that example, we have someone who's functioning at a very high level, and we drop them down to the table and doing exercises like that. The pain will likely feel better because we're not doing anything
Yeah.
except some basic movements. So lo and behold, it worked. Great. We figured it out. It worked. Now, how do we get back to where we were? We have to play this guessing game of how far to push it. Do we go right back to the gym? Do we do some body weight squats first? Do we try with the barbell? Do we do a leg press? All of these questions as to where we go from the bridges and bird dogs back to our training. So the approach that I like to take is, if we're squatting with a barbell at a high level, rather than dropping all the way down to zero, we just take one baby step down, and maybe we'll make that squat a box squat. And then if we can load the tissue and structures in that with that little modification, great. Do that for a week or two, and then slowly try to integrate back up to that barbell back squat. Not that the barbell back squat is necessary, but in this hypothetical example, let's just say the goal is the barbell back squat. If that box squat didn't work, no problem. Let's try something else. Let's try lowering the load. Maybe it's a load thing that's triggering it.
Yeah.
Maybe it's a range of motion thing that's triggering it. Maybe it's an exercise selection thing. Maybe we'll try front squats. Maybe we'll try hack squats. Anything we can do to kind of make these slight modifications. And then once we find somewhere that we're able to load it and comfortably and not provoke the pain, then we ride that out for a week or two, and then we slowly progress the same way, just in reverse, back up, because now we have this stepwise approach, so there's no guesswork. So that's I think where physical therapists in general get it wrong. I think we tend to drop down to the
Yeah.
TheraBand and clamshells and bridges and electric stimulation, ice, heat, all these type of things, massage, and I think we need to focus on that more active and kind of gradual modification and then gradual build-up approach.
Yeah, because keeping that skill and training around that movement is absolutely necessary, because we want to protect that skill, we want to protect the conditioning of the athlete, or even for a general population, because stopping is not an option. And in the all the literature, we have seen that movement is the answer. That we have to incorporate some sort of a movement which correlates with the movement that you are used to doing or you are going to do, which is the best bang for the buck. We just reduce the intensity of the movement, but we have to keep some type of a similar movement that you are used to perform. And on the similar note, Nick, I have heard you mentioning a lot of time that and other coaches like Quinn Hannock and clinical athlete as well, that pain is just like a sensation, just like hunger, just like thirst. It it's a symptom to see if there is any kind of underlying cause behind it. So a lot of time we started chasing to cure that symptom, neglecting the cause behind it, right? It's almost like if you're having a fever, you take a paracetamol to treat that heightened temperature, but that fever is because of typhoid, because of malaria, because of any kind of underlying principle. So if you are just lowering down your stimulus, lowering down that neurotransmitter, that symptom, you are lowering down the symptomatic things, you're not curing the actual disease behind it, the actual cause behind it. So how this particular pain work in this paradigm is pain in just in our head, or is it something else? So how you define it in terms of as a neurotransmitter or as a somatic nervous system a response to our own actions?
Yeah, so I'm glad you brought that up. That's a really great way to, and one of the things that I use often to explain pain to patients is I like to explain that pain is just a sensation. Think about, and I use hunger as an example. If someone were to eat breakfast at 9 o'clock in the morning, and then at 11 o'clock or 10:30 they go for a walk and they walk by a bakery, or they walk by some kind of fast food restaurant or something, they may smell that food and they may feel the sensation of hunger. Now, it's not that we're starving to death. It's just that our body is communicating something to us. Very similar to pain. We can have that sensation, but it doesn't mean that our disc is exploding. It doesn't mean that our rotator cuff needs fixing. It just is your body explaining something to you and trying to communicate with you. Whether that is, hey, we've been doing this one movement too much, too often, and with too much load. That's how your body says that with pain. It can't tell you that in your ear, so it gives you stiffness, it gives you pain, it gives you some weakness. Just so the other thing that you said was what was the other question you asked?
The symptom versus the cause behind it.
Yes. The That's another great example, and one that I use often is comparing it to medicine, because with medicine we have a root cause. We have a certain type of bacterial infection. So the difference is if I go into the doctor with a fever, just like you said, that's like having pain. It's the symptom. The doctor will, in a hypothetical example, will take some kind of sample, and he or she will diagnose me with a specific bacterial or viral infection. Once they have that result from, by the way, the test that is valid and reliable to properly
Yeah,
diagnose that, now they have a series of steps to take to to help that specific
problem.
pathogen. We take a certain type of antibiotic. We take a certain course of treatment to attack that very specific thing, and we feel better. The problem is that we try to do that in physical therapy, but we can't because we don't have, number one, we don't have the tests to accurately diagnose something. We don't have the tests to say this is your rotator cuff, this is your lower back. Um, Even if we had those tests, say a magic genie came and the genie can make perfectly clear, make us all aware of the certain structure that is quote unquote damaged. Even if we had this perfect test to diagnose, we don't we even if we were able to treat it, we know that wouldn't necessarily cure or fix our
Fix the
pain.
Yeah,
And then the other part of that, the third part of that, is that we don't have treatments, one steady course of treatment to treat that specific thing that we're testing for. So we can't diagnose it with a test that's reliable and valid. We can't treat it with a course of treatment that is well established in the literature. And even if we could do those things, it probably
there's
wouldn't
no
get to the
guarantee.
get to the root
Yeah,
cause
yeah,
of the
there's no
pain.
guarantee.
So that's the issue with when physical therapists or anyone in musculoskeletal rehabilitation, when we try to put a medical uh, paradigm into our profession. And the main issue, I think, well, one of the contributing issues is that that's what patients have coming into us. They come into us
Yeah,
with that expectation. They say, I have an MRI that shows a rotator cuff tear. How are we going to fix my rotator cuff? And then we have to kind of just, through time and education, kind of reframe them a little bit. But I think bringing that medical stepwise approach into physical therapy is where the downfall happens a lot of times.
exactly. And we have seen that even if your imaging test or some kind of MRI is showing you have a tear in your rotator cuff or you have a disc bulging, we have seen a lot of people telling you they experience no pain, even though they have the tears. On the other hand, the opposite side of the spectrum, people do say they have excruciating pains, but imaging shows nothing within their body. So there is so much murky areas. It becomes really, really hard. So when it comes to these kind of situation, what is your game plan? How do you handle these kind of a situation when the symptom is there but there is no cause to identify that? On the other hand, when the cause is there in the imaging but there is no symptom, so how does this paradigm works out in your day-to-day work?
Yeah, it's I don't blame the patients. Like it's not they don't know this stuff
Yeah,
and
they don't know.
right. So
Yeah,
it's like if I try to think
benefit
of
of doubt. Yeah, yeah, we can
right
give the benefit of doubt to them.
right. I try to think of it. I put myself in any kind of other realm that I'm not an expert in, and I think to my let's say a car for example. I don't really know the first thing about cars. There was an example I like to give a lot is there was a time a couple last year or 2 years ago or so when I was driving my car and I smelled like a gas smell, like something burning, like burning rubber, like burning gas. And I'm like, what is that smell? And at the time, my wife was pregnant with my first daughter, and we were in the process of getting a new car because we needed a car that could fit a car seat
Yeah,
or something or other. Oh, it was my second daughter because we needed a car that could fit two car seats. Not relevant to our conversation, but so we're trading her car in to get a new car. So my car had to be reliable because I wasn't about to buy two cars. My car had to be rock solid so that we can get this new car for the babies. So I started smelling this gas smell. My first thought is my engine is shot and my car
yeah,
is done. It's an old car and it's gotten me this far and now it's done. I'm going to have to just get rid of it and get a new car. That was my initial thought. I bring it to the mechanic and I just have the worst in mind. I say, I'm smelling this gas smell and I don't think it's safe to drive. So we pop the hood and he notices the cap to my oil was off and it was stuck on the side of something. And every time I was driving, there would be a little drop of oil that popped out and landed on my engine, and it would get hot, and I would smell that
hot.
burning smell. What happened was I got an oil change like a week or two ago at the time, and the person who did the oil change never put the cap back on the oil. So it was sitting on the side of the thing for the past week, and little drops of oil were popping out. The mechanic simply showed me that, put the top back on, cleaned my engine, and said, "You're good to go." Now, I
Yeah,
took that experience and really brought it back to the patient coming into the office. The patient develops some low back pain. Say it's a weightlifter and they develop some low back pain and they start feeling some pain on a squat. The first thought, very much like me, may be my time has come. Everyone says that you can't work out for your whole life because just wear and tear, it's bound to happen at some point. This is my time. I could feel my disc popping out of my spine every time I bend over. I know it's my disc. I know I herniated a disc. I'm going to have to get surgery. I'm not going to be able to squat anymore. Am I going to be able to pick up my children someday? And this cascade of thoughts happens. When they come into me, I have to take the role of my mechanic. I have to say, look, it's totally fine that you feel this pain. I know it's severe, just like the smell of gas is not nice to smell in your car because it's indicative of something bad happening.
yeah,
But let's just sit down, we'll talk a little bit. And so that's kind of how that conversation starts. Back to the imaging. It really it depends on the individual. If that person comes in and they're fearful of their MRI or fearful of their X-ray that shows bone-on-bone arthritis, which kills me every time a patient comes in and says that there was some kind of medical provider that said you have the knees of a 90-year-old, you're bone on bone arthritis, and that is just the worst kind of message that you want to send to patients. So I just say, just like you said, I say we have good research that shows us that we can have arthritis, but it's pretty normal over the age of 40 to have some kind of arthritis. Doesn't always have to be painful. We have people that have bone on bone arthritis that don't have any pain. We have people that have a little bit of arthritis and they're in a lot of pain and
A
stiffness.
lot of pain.
Same thing with herniated discs. We find that they're kind of normal to have. Living on planet Earth, it's normal to kind of have a little bit of disc herniation here and there. The spine is not meant to be completely symmetrical and stable. Um, your spine is actually very resilient. The discs are not jelly donuts. They're actually really, really firm, tough structures that don't just pop in and out like a little balloon. Even with the shoulder, the rotator cuff, the labrum in the shoulder, we know that we can see some tears in the rotator cuff and doesn't necessarily have to be painful. What I usually say is, when did this pain start? When did your knee pain start? And maybe they'll say, maybe like about 2 months ago I started feeling it. And I say, okay, arthritis doesn't happen in 2 months. Arthritis happens over years, it develops. So don't you think it's reasonable that you've probably had this arthritis way longer than the pain? And then maybe they'll say, oh, yeah, that makes sense. Like, I guess my x-rays probably look similar 2 years ago than they do now. So then I'll say, so just understanding that, maybe there are some other approaches we can take where we don't have to fix your arthritis, but maybe we could take have some other impact on pain. And then another example, like we said, the shoulder. Sometimes I'll use the example of so we got an MRI of your shoulder and we noticed that there's a rotator cuff tear. It's possible that you've had that tear for the past 20 years, never
Yeah.
knew about it, and now you develop some pain. Unless we have an MRI on day one, it's
Versus
perfectly,
today.
perfectly
Yeah.
fine. And then on day two, after you started feeling your pain, then we have a tear in your rotator cuff. Maybe that is part of the reason why you have pain. And again, don't we kind of said in the beginning, like, don't get me wrong, sometimes the structure can be causing pain. And that's
Yeah.
where things like surgery come into play. And surgery helps sometimes. For the right person, sometimes the answer is surgery. We try conservative care, maybe it doesn't work. We try to modify different activities in and out of the gym. And sometimes it doesn't work. And sometimes getting medication, some kind of injection, or some kind of surgical procedure, sometimes that is the best course. But for the most part, the findings on an MRI or an X-ray are simply there to rule out red flags, fractures,
Yep.
tumors, things like that. It's not meant to diagnose a specific pathology, and it's not meant to guide the course of treatment after that.
Exactly. So this is the really, really good message to all the listeners who will be listening to this podcast. We are not here to sending out the message that pain is just in your head and nothing else matters. You just have to burn through that particular exercise, or we are asking you to work hard. But we are saying that it's not a black and white area. It's not completely good. It's not completely bad. It's a shades of gray, and you have to acknowledge all the shades of gray if you really want to know the truth behind it. If you want to assume it, you can assume it as anything, but if you really want to deep down analysis and know the truth behind it, you have to acknowledge that these are the shades of gray. And on that similar note, that pirate analogy that you used to identify that what pain is, right? Captain versus pirates analogy that you used to give to a lot of people. I would like you to throw some light on that analogy so that people can get this perspective as well when it comes to the pain sensing and management.
Yeah. So I'm surprised I didn't use those analogies yet. Usually I usually jump to use them.
Yeah,
So two analogies that I like to use for pain. One is the spider analogy. So if I have a fear of spiders, and I want to decrease that anxious feeling around
sensitivity.
spiders, I want to desensitize that response to spiders. I'm not going to dive into a hole of tarantulas, because what that would do is that would reinforce my anxiety. It would make me so much more heightened. I probably wouldn't even be able to look at like a ladybug and not have anxiety. Any kind of insect would probably freak me out. Similarly, I don't want to just avoid all spiders, because
Yeah,
then when I do see one, I'm going to have that same response. So what we want to do is take that spider and maybe put it on the other side of the room. Walk into the room and your heart may start racing. Deep breath in, deep breath out. Just kind of live in that moment. Let that response calm down and then call it a day. The next day, do the same thing until that response gets lessened. Then you take one step further. Keep doing that over the course of a week or two. One step closer, one step closer. Throughout this process, we are going to the edge of discomfort, but we're not falling down that spiral of that symptom. So we're pushing it to the edge of discomfort, and then we're breathing, we're letting it sink in, we're accepting it, and we're becoming more resilient, and it's getting desensitized. Over the course of weeks, ideally we would be next to the spider and not have that anxious feeling. Obviously, in the living, breathing human, it's not always that clear cut, but that's kind of the idea. The pirate example, is so if you have a ship with the captain and the first mate, and the captain sees a light in the distance. Um, the stimulus is the light. It's just a light. That's all that we see. The response is going to be dependent on many different things. So, say the captain he just heard, he was sitting at the pirate or the bar, and all the sailors in the bar were talking about different run-ins they've had with pirates. Um, he sees this light in the distance, and immediately he thinks that it's danger, right? He
it's a
thinks
pirate attack.
it's a pirate ship. He tells his first mate, "Look, we need to get all the cannons ready. We need everyone, all hands on deck. Like, we're fighting for our life right now." So everyone gets on ready. Everyone gets ready to fight, and then they realize that it's just a lighthouse, right? So the captain's past experiences, his psychosocial impact, led to that simple light having this whole cascade of responses. Now, if he wants to decrease his fear of pirates, um, we would see that light and then maybe just get like half the cannons ready, like if he still feels that. And then after over time, when he sees that, when he or she sees that that light doesn't always mean danger, then that will get desensitized to that response. Um,
Response.
so yeah, the idea is that there is room between stimulus and response. So we have a light, we have a spider, and then there's a lot of different steps that happen before we get the response to the stimulus, and that's where we can have an impact.
Exactly, perfectly explained. So now that we have established a baseline of what pain is, what injury is, what pain could be, could not be, and what injury could be and what could not be. So on that paradigm shift, how to prevent the injury? Because management and recovery of injury is comes afterward. First line of care should be prevention is always better than the cure, right? So what are your guidelines to the lifters or for a general population in day to daily life? What are the guidelines that you give to your counseling patients or on other consulting people, how they can prevent the injury in the first place?
That's a big question, and if anyone has the 5 exercises or the gadget that can prevent injury, they're not telling the truth, because nowhere in the scientific literature do we have a clear cut
Yeah.
pull away from the crowd, this is the answer to prevent injury. What I suggest is learning this process that we're talking about and going through it. So one of the most beneficial things to do to prevent injuries is to get injured, because if you go through this process, it will make you more resilient moving forward, because then you'll take the tools that you learn throughout the process and apply it to any other pain or ache that you'll get in the future. That happens all the time with patients and athletes that I work with. We'll treat one issue that they're having. We'll go through this process. A lot of the things that we've talked about here, we'll not only talk about them, but the athlete will see it happen in real life, and they'll go through the process and they'll see, wow, this is actually true. It's actually working. And so having that mindset is the best thing you can do to make yourself more resilient moving forward, because then you won't even register an injury in the future, because you'll start
Yeah.
feeling some pain and you'll say, well, I'm a little bit achy here today. Maybe I'll just switch up the movement, and you won't even think about it. And you'll kind of go with a little modification. Maybe you change your foot position on a certain exercise for like a week, and then you go back to it and it's gone, and you never even think about it. So we just prevented an injury. But the way that we did
Yeah.
it was just through education and having good understanding of this paradigm of how to approach pain. So nothing really physical, nothing really preventative exercise wise, no real stretches, nothing like that. It's more just a global understanding of pain and injury, having the right glasses on to look at the world.
Yeah.
Almost like, if another analogy I like to use is using a map, right? If you're in New York City and you have a map of London, it doesn't matter how great of a driver you are, you're not going to get where you want to go. So if we get that right map, I think that is probably the key to injury reduction and management.
Definitely, I can totally relate to that fact. I have an insight to give it. So I was doing a really good amount of intensity and volume of the RDLs, and every time I go past a certain amount of range of motion, I had never been that issue before. But it's because of either I was getting fatigue in my mesocycle over the time period, or it's just a overused thing. Our connective tissues are not as strong as our actual musculature, right? So every time I was going using the same load, using the same volume, almost like fourth to fifth week of my mesocycle, I used to have this kind of a pain, achiness feeling on my lower lumbar or upper side of a right glute. So every time I used to go to that particular extra hip hinging movement or hip extension, I used to feel that thing, and it got me thinking ki I am better than this. I have become a bit wiser. So instead of just going through the motion and becoming a bit pedantic about it, let's take a wise decision. Let me just cut that range of motion. Yes, I might not be getting that full range of motion benefit for the time period, but it might keep me safe. And I took that approach, did it for 2 to 3 weeks, 2 to 3 microcycle, had a deload. Once again, I came back, performed that full range of motion. Now it's not there. So it somewhat tells you over the time period that you have to become wise, you have to listen, and you have to adapt accordingly if you want to be in this game over the lifelong period of time.
Yeah,
So what do you see?
yeah,
Does that correlate well with your example?
100%. And myself, I can tell you a ton of examples when I've done that in my own training. And if someone asked me, how many injuries have you sustained through bodybuilding, I would say none. But then if I
None.
actually think
Yeah.
back, it's like, well, I guess I have pain sometimes when I do things. So, for example, I guess one that recently just happened, since 2019, the end of 2019, right before the pandemic, my first daughter was born. So I set up a basic little training section in my basement. Got a little adjustable bench, had a barbell, some weights, a little squat rack, all the essentials to do pretty much a full workout, everything I needed. Also, I got a sissy squat rack, or however you want to call it. Um, I love it. That thing's awesome, especially for a home gym. Anyway, so the only pressing movement that I could really do, the only horizontal pressing movement I could really do was a barbell bench press. Yeah, I could do some deficit push-ups, and I didn't have
Yeah.
dumbbells that were heavy enough, so I would just have a barbell bench press. Never had issues with my shoulders, really, like nothing serious. I would say, so this was end of 2019. I would say about 2 years of just flat barbell bench pressing. I started developing a little bit of pain in my shoulder.
Yeah.
I noticed that if I lowered the load a little bit, it would feel okay. So initially, I changed my reps from like 6 to like 12 to 15. I lowered the load, focused on a bit more of like tempo and that the eccentric, getting a good stretch at the bottom and coming back up. Felt good for a couple weeks. Then that started bothering my shoulder too. So the next thing I did was I put the bench one notch up, almost like a little bit of an incline, just a little bit up. And I said, well, let me just try this, see how it feels.
Let me just try.
When I tell you that it was completely, I couldn't make it hurt if I wanted to. Like it felt so good. And then I've been benching with a little bit of an incline ever since. Will I go back to flat bench? Maybe. Like it's not my goal to
Maybe.
bench flat, but if I did want to go back to a flat bench, what I would do is I would maybe start with, if I'm doing 4 total sets, I would start with 3 sets on a little bit of an incline and then 1 set flat with some light weight
Yeah.
just to kind of get a feel of it. If that feels okay, maybe the next week I'll do 2 sets on the incline and 2 sets on the flat and see how that feels and kind of just gradually work back into it. But it's because I guess you could say that I prevented an injury, but it's not because of anything special other than me just understanding that it's just trying to tell me something. It's just trying to tell me,
Yeah.
hey, we've been grooving this same movement for 2 years. Maybe we should try something different. However, if I had a different paradigm or different map that I was using, when I first felt that initial pain, maybe I would have gone to see an orthopedist. Maybe they would have done an MRI and shown a torn rotator cuff that I had when I was 18 from playing sports. Then maybe they would have given me an injection. Maybe I would have gone to a physical therapist and he or she would have given me rotator cuff strengthening exercises because the reason I have pain is because my rotator cuff is weak. And I say that's weird because how is my rotator? But the point is now I'm down this whole other path of me feeling disempowered and me feeling weak and fragile. I'm not training and I'm just doing these low level exercises where I
Yeah.
didn't have to do any of that. All I did was just make a few modifications. I maintain a training stimulus. I'm still training heavy. I'm still going to fatigue and my shoulder feels much better. So that's a perfect example of the two different paths that we can take. And one is the very biomedical, very disempowering path, and then the other one is that uh, more enlightened approach and more empowering and one that keeps you training, keeps you doing the things that you love without provoking that pain.
Yeah, it's just like there are multiple ways to skin a cat. Sometimes you just have to change your ways, but that doesn't change the destination. Multiple roads lead to Rome. You can choose or switch your particular roads depend on the traffic so that you can still keep on going, still trying to achieve your destination. But the path sometimes may be not the one that you have always been gunning for. And I can totally relate to that bench press example. It's because my anterior delt is attached so far forward to my clavicular. uh, it makes my shoulders become the prime mover whenever I do a you can say flat bench press. So either I always have to do some sort of a incline around 10 to 15 degrees or some sort of a decline around 10 to 15 degrees, and I feel really good thing on my chest. Otherwise, because I was married to the thought everyone does flat barbell bench press, That's how Arnold made his chest. That's how the world best bodybuilders have made their chest. I have to do the bench press, right? In the initial 3 years of my bench pressing, my shoulders got so good, but my chest lagged. And everyone was like, "You have such a great shoulder genetics." I was like, "No, man, I was doing shoulder press, but lying on the bench press. That's it. That's how, because I had no knowledge of human anatomy. I do not know how insertion and origin works, and I was married to a thought. But then, as I started learning more, I became much more experienced, much more wise. I got a degree in sports and exercise science, and then I was like, "Oh, this is why I used to feel better on my incline and decline as opposing to the flat bench press." And overuse injuries do happen. We get specific adaptations, and we get adaptive resistance as well. So sometimes doing biceps curls twice a week won't give you any kind of a pain. But the moment you switch the frequency to thrice a week, you get tendonitis. So we have to be make sure we know ourselves first instead of directly jumping on to this medical care and going to that biomedical pathway. That's a really, really good way to put it.
Yeah, I think that was a great example. And I know, I think Alberto used to bench with a little bit of an incline as well,
Yeah,
most of his pressing. If so, let's say my example here with the shoulder pain with flat benching. If things didn't work out like that, how it went in my instance, say it kept getting worse. I kept trying to make modifications. I put the bench up a little bit. It still hurt.
yeah,
I lowered the weight. It still hurt. Um, Maybe we get rid of the bench press and I just do push-ups from now on. If that even hurts, okay, we move on to the next thing. Maybe we could do like hook like a resistance band up around something and maybe just do any kind of like
flying.
chest, like just kind of squeeze the chest, get some blood flowing in there. If that even hurts, then I would say, okay, maybe we'll hold off on pressing for now. We'll continue other training if everything else feels okay, and we'll work our way back to it. If I started feeling pain throughout my day outside of the gym, if I couldn't hold my daughter because my shoulder hurt, if I couldn't reach for the refrigerator door because my shoulder hurt, if I was getting woken up at night because my shoulder hurt, if the pain was constant, if I started developing like radiating pain down my arm, then I would go see a medical provider. At that point, I would go see a medical
Yeah,
provider because that is where things like medication can come in. Medication, an anti-inflammatory, some kind of injection, that will kind of like control alt delete. If your computer is not functioning, it will kind of stop that cascade of increasing pain. It will temporarily decrease that guard and then it will allow me to work back up to loading the tissue. So I could start with maybe some isometrics for my chest. I can start with some of that band work. I can start with maybe some push-ups where I'm holding on to a table, so it's not all the way on the floor. I'm just kind of doing like a modified push-up with my hands on a table, and just start getting the shoulder going through that range of motion again, so that I can take advantage of the artificial decrease in pain that the medication is helping me with, and go from there. If that doesn't help, if I get an injection, if I get some medication and it's still getting worse and worse, then we would take the next step. We would get an MRI, do some kind of imaging, and then go
yeah.
down that road. But only if all of those things happen and this pain is just so severe and so um, uh, unmodifiable, that is the only time when I would say let's go down this road and use these providers because that's what they exist. That's why they're there. They, like we said, they have their place. But I just think we need to try to do some of those steps like you and I are talking about before we go down that road.
Definitely. I really, really loved this sentence of yours, and I want to emphasize our listeners who will be listening to this particular podcast is if the Dr. Nick himself, he is a doctor himself, is telling you the first course of action is not to directly jump on any kind of a medical practitioner or directly book a cab to the medical college or you can say hospital. The first line of defense is cost free. Do your own analysis, become a bit wise, try few other things, try few other methods, see how other loading patterns work, see rotating few exercises, do some kind of modification. It's almost like a zero cost investment. right? You are investing nothing and you are getting a lot of information, because if you are getting success out of it, it will leave some clues, right? Even if you are not getting success out of it, it will rule out the other possibility. So it's a win-win situation and you are not losing anything, because you have nothing to lose. You are already in a pain. If nothing works, then obviously you have the biomedical route, which Dr. Nick always has just mentioned. So this is a really really good message to all the listeners. So if you are facing these kind of a niggles, pains, and injuries, you are thinking that you might be injured. Try these things. First line of defense. Nothing works for a certain amount of time, then obviously go for the biomedical route. Because if a doctor himself is telling you that you should try the first line of defense by yourself, there's nothing harm in it, right?
Yeah, and um, that's 100%. The one thing I'll say is, as you're going through that process, as you're trying things on your own, you don't have to be alone. You don't have to
Yeah,
guess how to modify. You don't have to. So in my example, I said, well, I put the bench up. I would start with some band work. I would do some isometrics. That's for someone like myself to help you with. I can, not just me, but someone or like me,
yeah.
or we can help guide you through those first steps, so that you don't have to be so cautious, or just kind of pull things out of thin air, because it's nice to say that we have to try conservative care, and we have to try just to make some modifications. But then there may be listeners out there that say, okay, like, but there are so many ways to modify my training. Which is the right way? What if I choose the wrong way? So that's where it's the
Which is
best.
why, yeah, which is why people like us exist. Like, this is why.
Exactly. Exactly. So that is when you need to just reach out to someone like us, so that we can guide you a little bit. You want to nip these problems in the bud before they get into something bigger. You don't have to do it alone. That's where we come in to kind of guide you through that modification, guess and test type process. So yeah, I just wanted to make sure that was clear, that you don't have to do it alone. We're here for you if you are
Yeah.
going through something.
Exactly, because the last thing we want is for you to go through an exercise science degree procedure, or you can say becoming an RPT first, and then you start modifying your exercises. You can always reach out to some, and the reason we are able to give this insight is this paradigm shift which we are seeing, that we have been meatheads. We came from that bro lifting culture, and then we adopted that scientific culture. So we have both the perspectives, right? Generally, if you see any kind of medical doctors or in general practitioners, there are a lot of people who have never lifted, and if they have recreationally lifted, they haven't done a competition prep or a weight restricted class prep, right? And a lot of time their guidance or their guidelines are not based on the catering to an athlete. It is for a general population. And you can also uh, uh, vouch on it, Dr. Nick, that a lot of niggles and these pains happen at a certain body fat percentage level. Since when we get to diet down during a contest prep, I have the same kind of insight that my right glute always starts paining and still starts getting stiff when I get around 10% body fat, because I have less pliability, less cushioning around it, more wear and tear. And so, do you have any kind of insight on these kind of things you want to share with the listeners, that
Yeah.
not all your body is ever changing, right?
Oh yeah. So funny you mentioned that, because so when it comes to a contest prep, we are in a fatigue state. Things like sleep is affected.
Yeah,
Overall energy is less. Where everything takes more effort. All of those things are going to contribute to increasing that pain sensitivity. Where maybe something that gives you a little bit of pain and then goes away, maybe that little thing just lingers a little bit longer if we're in a contest prep. Funny you mentioned your right glute. So my last competitive season was 2018. Um, so I didn't have the symptoms in 2018, but rewind a little bit. I competed in 2016, and I was getting like sciatic type symptoms
yeah, exactly.
from my glute, the into like my back of my thigh, and this was before I really I was just freshly out of PT school, and so I felt tightness in the back of my thigh. So I said, well, it's tight. I need to stretch. So I would stretch my hamstrings. I would do a lot of foam rolling, and then I realized that it actually felt worse after I was doing those things. But I said, well, I gotta just keep doing it because it's the right thing to do. Kept doing it, and just kept getting worse and worse. Um, and what I ended up realizing was the tightness in the back of my leg was not my hamstrings; it was my sciatic nerve. And the more that I stretched, the more that I tugged on a hot nerve, and they don't like that very much. So I was basically just making it worse and worse. And then I was also doing a lot of cardio walking on an incline. And when you walk on an incline, you're basically, if you think about the angle of yourself kind of walking, you're pulling on the sciatic nerve a little bit more than you would if you weren't on an incline. Um,
Yeah.
so those, for just to give a little bit of an image, if you were to sit down in a chair, slump your posture forward, bring your chin to your chest, kick one leg straight out, and then pull your toes up toward your head. Okay, if you can imagine that like letter C position, that is the position of like most sciatic nerve tension because it's basically like a little rubber band or that goes
Yeah.
up from your head down the back, down your back into your glute, down the back of your leg into your feet. So that position is where you stretch the sciatic nerve the most. So if you're on an incline treadmill and you're leaning forward with your head down, your arms are on the machine, and you're reading or looking at a video on your phone, you're basically hitting that position with every step. So it wasn't that I had weak glutes. It wasn't that I had a weak core. By the way, I was very hypersensitive over of maintaining a neutral spine. I did a lot of core strengthening because I wanted to stabilize my spine, which now we have good evidence to show that that's probably not the best approach. The spine is pretty darn stable as it is. Um, so once I changed my paradigm and I said, well, why don't I stop walking on an incline and I'll do the elliptical instead,
Yeah.
and I'll stop stretching my hamstrings and I'll stop foam rolling as much 30 minutes before my training session. Maybe I'll just modify these activities and see how it feels. And lo and behold, it started feeling better. Um, long explanation for I was in a contest prep at the time, and I think part of the hypersensitivity to all of that and the increased pain was probably because I was in a deficit. But just another example of how I'm very imperfect, but I've learned from mistakes of the past.
Exactly. The similar thing of how I got some kind of a scar tissue on my right glute is that Stairmaster machine, right? So I was at around 6 to 7% body fat and was like, being a meathead in my head, even though I was going through the exercise and everyone does Stairmaster to burn extra credit. This is the most so whosoever is listening will be listening to this particular podcast. One piece of advice: if you are going to do this down path of contest prep, do not do Stairmaster. It's just a concentric only movement. It will chip off the volume from your lower body. You won't be able to maintain your leg performance in your subsequent leg sessions. And that's how I got somewhat a micro tear on my right glute because of overuse injury. Because it's just a concentric movement. There is no eccentric part of it. So we all have learned from these things, and we have become wise to listen to our body and not just through it's a bronze game, but sometimes you have to use your brains as well. So with that note, Dr. Nick, even though we have gotten these kind of a explanation of a basic foundation of what pain is, injury is, how to prevent it, how we can make sure that we are not causing any overuse injury, at the end of the day, at some point of time, injuries are going to happen. If they are going to happen, it's inevitable. At some cost of time, we try to prevent it as much as possible. But when that does this happens, now what? Now what are your guidelines that if some sort of an injury happens, what should be our course of action to take from that point onwards?
Yeah, I would say use the same principles we've talked about. If it's really inflamed, if it's really sensitive, it may be a matter of just switching up or holding off on the movements for now. Kind of like in my one example where the shoulder just kind of kept getting worse and worse and worse and worse. I would just go down that process. And if it is that bad and you can't do any kind of a certain kind of training like chest or leg training, think of it as this is a long-term game. And in the short term, if we have to take a little bit of time off from doing certain movements, let's just do it. And then we know that it's better in the long term. I would just say try to keep it moving. If it's lower back, for example, and you can't do any loaded leg training, is that bad? You can't do anything at all. Go for a walk. As long as we're doing something,
Something.
ride a recumbent bike, ride anything that we can do to keep some kind of movement in there would be best. And then you know that you always have the the resources like us here to help along the process. You do have the medical system, which is good when it's used correctly, if it does get to that. But yeah, I would say just keep using the principles that we've laid out here, and no matter what's thrown your way, you should be able to to get through it and be more resilient in the end.
So that's the silver lining when it comes to injury prevention and management. The kind of brainstorming we have to do when it comes to the diagnosis of a particular injury, whether it's through imaging, whether it's to MRI, whether it's to your cognitive effects, or just through your symptoms, the cure is similar for each and everything, right? The particular preventive care or a management is almost the same for any kind of an injury. So, on that note, uh, are there any special procedures when someone gets injured, or the process is altogether together the same? We have to make sure that we are ramping up that stimulus from the ground zero, gradient exposure. Is it all the same in all the cases, or do you have any kind of insight based on your experience where you have to switch to certain kind of procedures where things are not working the way you want it to be?
Yeah, I would say it's the same principles, but then the course can be very different. So if you try the
Yeah,
graded exposure approach, but it's getting worse and not getting better, then that's when we just back off a little more. But the thing with principles is that they're consistent. They're always there, whether we like to believe in them or not.
yeah,
Another analogy I like to use is if we take injury, injury, recovering from pain, modulating pain, if we look at it like building a birdhouse, um, the principles of injury reduction and management are going to be similar to if we turn a screw to the right, it's going to go in. If we turn a screw to the left, it's going to come out. No matter how the wood or the material responds, no matter what kind of birdhouse you're building, no matter what, when you turn that screw to the right, it's going to go in. When you turn to the left, it's going to come out. Same thing with injury reduction and management. If you follow these principles and you let them guide you, everyone will have a different path that they take. Everyone's birdhouse may look differently, but the principles are the same. You turn it to the right, it's going to go in. You turn it to the left, it's going to come out.
great. And another analogy I have heard from you is like you used to mention that marriage analogy, right? There are ups and downs in a marriage. That's these are the downs which teaches you something, because success do leaves clue. So you want to share some insight on that analogy as well? I really loved that particular analogy when I heard.
Yeah, for sure. So I've been with my wife since we were, geez, 16. Um, and we have been through a lot together. We've been through going from being children to being adults to being parents. And throughout our relationship, we've learned the most about each other during the hard times. The good times are great. Everything's rolling smoothly. Everything is nice. But we don't really learn much about ourselves.
Learn
We don't
much.
really get resilient. We don't really dive in deep, have uncomfortable conversations. But when we have something going on and things just aren't right and things just keep getting worse and worse and worse, we need to sit down and we need to have these conversations. All right, I feel like you're thinking this that I meant by what I said, but this is actually what I said. And then the conversation gets deeper and deeper and deeper, and it becomes something that I said 10 years ago that just is like a seed in there that just keeps building growing like a cancer. So now we talked about that. We dove in deep. We know that I said something 10 years ago that really hurt her, but we never really talked about. And then when I left the toilet seat up, it just came out like this whole thing, right? So the point is that after going through that process, 6 months down the road, we are not going to have that same conversation. We may have a similar conversation, but if it does come up again, it's not going to be this deep, uncomfortable dive into this diagnosing the reason why we're having an argument. It's going to be, hey, remember 6 months ago when we had that conversation? I'm starting to feel those feelings again. So maybe we can do something like about that, or like when you did this one thing, it kind of brought up those feelings. So maybe we can talk about that. That is a whole different conversation than it was 6 months ago. So same thing with injury. Like we said before, once you go through the process, once you actually get injured or once you actually feel pain, and you start doing this process, you realize, wow, this actually is how we grow and get better. If we're trying to grow a muscle, we have to break it down. We have to
Yeah,
break it down and then build it back up with sleep and recovery. It's uncomfortable. It's physically uncomfortable to go to fatigue in the gym. It's physically uncomfortable to have pain. It's uncomfortable to be uncertain about what's going to happen with your pain. It's uncomfortable to have this kind of argument with your spouse or significant other. But the light at the end of the tunnel is that you grow, you become more resilient, you learn more about yourself, you learn more about your significant other, you learn more about pain, and in the end, it is a blessing in disguise. So the hard times are awful, but just find a way to plow through and find a way to take the little lessons that you can learn throughout it, and they will make you more resilient moving forward.
definitely. Because a lot of people, when it comes to whether in terms of a relationship or in terms of an injury, if you are not addressing the issue, that particular issue is gonna get bigger and bigger. If you are just piling it up and just trying to let go of that particular issue and thinking that it's gonna resolve on its own, it's gonna pile up. The particular intensity is gonna increase over the time period, and once it's break out, once the bubble burst, you won't be able to take it out to handle it. So, in order to address the issue, yes, you are going to have uncomfortable conversation with your spouse, or you have to make a lot of modification when it comes to the injury that might seem really, really uncomfortable at that particular point of time, but it will make you a better human, a more wiser human. It will teach you a lot of things, that there is light at the end of the tunnel, there is silver lining in everything, and it's through your downs where you actually learn how to become and come out even stronger and learn from them. So that's a really, really good analogy that you have given around the listeners. And on that note, I have advice for the listeners. So along with the injury management, if you want some relationship advice, you can always reach out to Dr. Nick. He would be more than happy to help you. Because
Absolutely. And just like as a physical therapist, I never have pain. As a marriage specialist, I never have any arguments with my wife. We've never yelled, we never said anything that we didn't want to say. And the difference between pain and marriage is that pain, sometimes you have to modify and sometimes you have to change what you're doing. Marriage, I'm just always right and my wife is always wrong, so we don't have to make any modifications. I just keep doing what I'm doing because I know that I'm right. So there is a little bit of difference, but it's in, neither here nor there. But the analogy works, but it's a little imperfect.
yeah, yeah, he never puts his seat down, toilet seat down, so he doesn't care because he is always
Right.
right. So with that segue, we have covered a lot of things. So now that we have identified that we have been injured and we don't know, as a general layman person or as a general population who is not having a RPT degree or exercise science degree, now how would we identify whom to approach? Because that's where the issue happens. Finding out the right person when it comes to guiding you in your injury management or any commodity or modality in your life, it's the first hard thing that you need to do, and you have to put a lot of thoughtful endeavors and effort in finding that person. So what are your guidelines when it comes to finding that expert? What you want to like put out for the general listeners so that they can identify differentiate between whom to approach when these hardships do happen in their lifting career.
Yeah, it's a good question, an important one. I think you can really start anywhere, but then make sure that you're asking the right questions. See how the provider responds. If they don't give you the time of day, if they're very short and quick in the office, out of the office, take this anti-inflammatory and stop squatting for 4 weeks and come back and see me after that. Go get a second opinion. If the person, if you tell them that you're having pain and they focus solely on the structures at hand, like the knee, your knee hurts because your hips are weak and you have this, then that's also someone you may want to question a bit more. If they don't listen to learn more about you, learn more about your hobbies, learn more about your goals. If they don't take your not only the bio but the psychosocial aspects involved, you may want to either question them a bit more or get another opinion. So it's kind of hard to say who to go to. Um, I don't think there's I don't think the practitioners are to blame if they're not the best choice for a bodybuilder or a weightlifter. Because if someone came to me who rides horses, I probably wouldn't be the best person
Yeah,
to go to. If someone was a high level baseball pitcher, I could hold my own with a baseball thrower, but there are people out there that see that every single day and just work with baseball players every day. So no fault of my own if I'm not the best person to see, but maybe I can refer them somewhere. So no fault of a general practitioner or a general orthopedist if he or she isn't an expert on weightlifting. But that just means that maybe you need to just find someone who is an expert
yeah.
or question them a little bit more. So that's probably what I would say. I don't really know who to say to go to, like in your geographical area, but just having that mindset of trying to
Basic
find,
guidelines.
yeah, the
Yeah.
guidelines exactly.
Yeah, exactly. When someone asks me that if they are going through some kind of an injury or they are prone to injury, so I always ask them that these guidelines that we have been received in our university at my time in Luguru when I was going through my bachelor's in sports and exercise science, that always go to a sports doctor and see what kind of athletes or people they have experience in. So their experience, their previous past history of handling their clients teaches you or tells you a lot about that particular practitioner so that you can make that calculated decision whom is best for your use case scenario. Just like you said that a horse rider, if it comes to you, you might be able to help him, but it would be better for him to go for a practitioner who has a huge list of clientels who are from that similar background or similar sport. So that's always my go-to recommendation is see who is been working in that particular sports athletic endeavor field and who has been handling your type of demographic or population sample and then go around it because a lot of time general practitioners it's not their fault that they are not very well versed with the athletic handling endeavors, right? So they will treat you as a general population, and that's how the particular things do come into the play. So the history of that particular practitioners matters a lot, their experience matters a lot, but it has to be specific as per your needs, and you have to ask the specific question because that's what science is. Science only tells you the answers for specific questions. It doesn't tells you answer for all the questions. It will tells you the answer for the questions that you ask.
Yep.
So once now that we have identified our go-to practitioners and we have talked a lot about the basic foundation of what pain is, what injury is. So now one this question tells and comes into the mind of a lot of people that time off versus active recovery or the movement. So what are your thoughts on that? So a lot of practitioners or medical doctors or even RPTs recommend complete time off versus what the literature actually says that doing an active recovery or going through certain movements is better than actual time off. So what are your thoughts and what are your insights on this?
Yeah, I think it kind of goes back to like we said before, how if we have that person that's functioning at a high level, and then we drop them down to the table
Completely.
exercises, the bird dogs, the planks, that's not what we want to do. We want to maintain as much of that training
Conditioning.
effect as we can, So if the only time I would say to rest it is if it, like in my cascade of shoulder hypothetical example, if that thing is just so sensitive that nothing, any kind of movement makes it worse, then that is your body telling you it's time to just rest and let it recover a little bit and then gradually work back into it. So I would always err on the side of as much movement as you can without provoking it, but sometimes rest is the answer, and that's going to be individual to everybody.
Yeah, yeah. Especially in strength and conditioning side, we always see we can totally correlate with this that uh, uh, active recovery or a deload is better than a complete time off, right?
Right.
And on that example, I was talking to Dr. Eric Helms as well. So when he was going, when he mentioned that he had bilateral hip surgery, and his attendant doctor told him that 4 weeks of complete rest, no exercises. Then he explained that can I do machines? Can I do leg extensions? Can I do leg curls? I'm not going to actually load it or something. So when he explained the rationales, because he had a background in exercise science, he was able to explain the rationale behind it. So it makes sense to have some kind of movement versus complete time off, right?
Exactly. Yep. Yeah. Always do as much as you can. Keep it as specific to the goals that you have, and that will help not only desensitize the pain, but it will help with the rebuilding process because then you won't have that much of a jump to go because you've only modified as much as you need.
Yeah, gradient exposure is what we are looking for, step by step iterations, which there has to be some kind of a thoughtful pursuit of your particular goal.
Yep.
So that was a really, really good session, Nick. Let's wrap up this particular talk of ours. And any kind of ending notes you want to provide for the listeners on like a little summary of what we have discussed, just a quick 30-second summary if they are going through.
Yeah, I think I would listen to this episode twice, three times. I think we talked about a lot of great things. Um, my one message would be if you are in pain, um, it's okay. There are resources out there to help. It is not the end of the world. It's not the end of your training. You didn't necessarily do anything wrong. It's not your fault. Sometimes things just happen, and there are ways around these aches and pains. And if weightlifting and exercise is foundational to who you are, and it feels threatened because you are in pain, um, understand that it's good that you're passionate about something like weightlifting and exercise, and you can get back to doing those things. So I'm here to help if anyone wants to reach out to me, and any of the other resources that we talked about on this episode. But yeah, other than that, I would say the best way to reduce your injury risk is just have the right paradigm, go about it with the right map, and understand the principles that we've talked about today.
Exactly. Well said, well summarized, Dr. Nick. And where can people find you?
So at Nick Licameli on Instagram, you can also find me at 3dmusclejourney.com. And those are probably the two main places to find me.
That's great. That's great. So we'll be keeping a catch on you. We'll be reaching out to you again so that we can have much more meaningful conversations down the line. And I'm really, really grateful for your time today and reaching out to me on this podcast. And I hope listeners will get a lot of good points when it comes to the basic terminology of what pain is, what injury is, how to manage them, and how to prevent them. So thank you for your time, Dr. Nick.
Thank you for
Really
having
glad
me.
that. Sure. With that in mind, let's end this podcast on a high note. I hope everyone who has listened to this podcast has learned some good things from this podcast. And if you have, please feel free to share this podcast with other people so that they can also learn some good things from this podcast. As of now, this podcast will be available on YouTube, Spotify, Apple Podcast, along with the Google Podcast. And you can also check out the MAS monthly application Instant Sport through the links which are provided in the description. So, till next time, goodbye.